What I'd like to do, and this is really an introduction and it comes a little late in AQO and a welcome, and at the end will be a thank you, is take you on a little journey through the phases of the evolution of what you're learning about and working on today, with new dashboards and many new things coming, and I think will continue to come. So I'd like to take you back first and talk to you a little bit about the Society of Thoracic Surgeons and the database emanated from them. This society started essentially in 1964 to disseminate information on thoracic and cardiovascular surgery and that field, and to offer a forum for young men. There were no board-certified women at that time, and to make it an inclusive society rather than an exclusive society. Now, that society existed, had yearly meetings, had conferences, and then in March of 1986, what was then really Health and Human Services, or HCFA, the Healthcare Financing Administration, decided to release a list of hospitals and the mortality rates of hospitals, and basically in some ways rank hospitals, although they implied they weren't going to, rank hospitals in coronary bypass operations by mortality. And although they warned everyone saying that this is not a totally accurate approach, it was the best that existed, and the public were entitled to these data points. With that, however, the STS, this group that really just had a yearly meeting, felt that the members of it then and the leaders of it then, that using these raw mortality data points that were not really risk adjusted, that did not have significant risk algorithms to them, was an unfair portrayal of how patients are treated at different hospitals. And with that, basically, the STS database was born. So it was born out of an idea to really use registry data from hospitals that submitted it voluntarily, just like all of yours do. Put it together, look at these data, create risk algorithms. In other words, come up with what is most important in how a patient does, process and outcome variables. The composites came much later, but this was felt to be a responsibility of a professional society, and thus really the birth of the database in 1989. Not to compete, but to have legitimate data points that we all could use. And then the evolution of the database, as you all know, with Jeff Jacobs, who's here today, Dave Sheehan is here today, from Richard Clark, who was the first surgeon really to orchestrate the database, through Fred Grover, who's been here, and Fred Edwards, who's been here. These are the leaders of the workforce on the database. Now, you've seen this chart already. The purpose of this chart is to really, not to have you read it, don't take a photograph of it, you cannot read it, I can't even read it from here. But it's really to show you the breadth and depth of the STS. There are over 65 employees, and this is the organizational chart for employees. I will point out, though, that Rob Winbrandt's right at the top. I can say that this is his town, but he's not at the meeting. This organization does many complex and deals with many complex things, including having an office in Washington, D.C., as well as the database, as well as many other tentacles, if you will, to the FDA, to other organizations. And it requires this many people functioning. So we are not just a database. And then if you look at governance, on the top of it is a board of directors. We actually have a board of directors meeting in San Diego on Saturday that several of the leaders here will be participating in. So the board of directors basically runs the organization. And as you know, the Council on Quality Research and Patient Safety Operating Board, which Dave Sheehan chairs, is, if you will, where the workforce on the databases sits. Now, you've seen this, I suspect, but the STS National Database, if I had a vote, I'd take national away and just say the STS database. But apparently it's branding. You know, your athletic teams have branding. I think we're afraid to take away national. because we have international participants. That includes a dotted line to ACC TVT, which Joe Bavaria will talk about a little later today. But it has adult, congenital, general thoracic, you're here for all of that. And we hope by January 1st to have the Intermax registry folded in to the STS. So there will be 4 major components under the STS National Database come 2018. There are 2 modules, you know about those as well. I think the anesthesia module actually may have a few more participants now. Neither of them have had robust participation in them. However, during the same period of time, starting with the organization, there are now nearly 7,500 members of the STS, both surgeons, researchers, allied health professionals, data managers such as yourself, and other allied health researchers as well. You've seen these already, I won't belabor this. Basically 95% of the United States cardiac surgical programs are in the database. The SDS just sponsored a meeting with the European Society EACTS in Cartagena, Colombia, and there is a great deal of interest in South America to now participate in our national database. So I think this will continue to grow on the cardiac surgical side. General thoracic is much more difficult to measure, as you know, and probably spoke about yesterday. Ballpark 50 to 60% of the centers that perform general thoracic procedures are probably in the database now. Congenital has done a very good job of voluntary recruitment, if you will, with essentially all of the United States programs in the database, and congenital anesthesiologists or pediatric anesthesiologists participating in a separate module that can link to the STS database as well, and there are international programs in the congenital database. Now, just watch this. We know you work very hard. Some of you have been here since Summit. I guess about 15% of you are new within the year.
8 pages, here they go.
So let's give you a little heritage here.
9 pages.
It only gets better.
17.
Now,
Wait. Oh my God.
so that's where we are today. And frankly, as we know, it may expand, but the STS is working on other things to help lessen, if you will, the data burden. These are not recreational data points. You want me to say that one more time? These are not recreational data points. Our patients, the care for our patients, how we can improve, how we can influence the government and other agencies are basically, it comes out of this registry. And what we learn about certain approaches to patients, percentage of mitral valve repairs versus mitral valve replacements. There's never been a prospective randomized study of doing mitral valve repairs versus replacements, but we all say it's better. We need the database to prove that. So all these are very important, and we're going to try to lessen the burden. But I thought I would share with you a little bit about what the STS does when it creates strategies and how this influences the database, and then how it influences you as well. We have a mission. All organizations, all professional societies have a mission, vision, and core values. Your hospitals have these as well, and they may essentially be very similar in wording. Enhance the ability of cardiothoracic surgeons to provide the highest quality patient care through education, research, and advocacy. Makes sense? Sounds good. Improving the lives of patients. Clearly, that is our vision. No questions about it. Core values, innovation, professionalism, inclusiveness, teamwork, and obviously diversity. Our goals and objectives, we want to be the leader of innovation and education and optimize that value with functionality and sustainability of the database. We realize there are many challenges. You just heard an excellent presentation on what a dashboard's going to be like, but it's going to take time, and it's going to take more time to have more people have access. and not have hackers have access. So all this requires time and energy. And we will, and we actually have a meeting coming up this weekend in San Diego to talk about transfer of EHR data points, at least the ones that we believe are safe to transfer directly from EHRs into the database to lessen some of the burden. We're not sure we want to take an ejection fraction that's in an EHR and automatically transfer that. We believe your role as data quality specialists, data managers, remains imperative for this. Facile upgrades, we need to do them much faster. We need to be able to add fields within 2 or 3 months based on new products and new opportunities, and improve the software that we have. Yes, some of this that we do needs to support research so we can come up with guidelines and the most appropriate procedures and what can be done, and stretch ourselves, frankly, using the data from the database both intellectually and pragmatically for our patients. You've heard about dashboards, patient-reported outcomes, very challenging reality. However, eventually that will become a part once we create facile ways to get that. And some of that depends on the patients, electronics, contacts with the patients, how to do it easily. We understand all that. And finally, long-term follow-ups with death registries so that we know how our patients do over 5 years, 10 years, 15 years, 20 years. And links with the FDA when appropriate. Training modules, online lectures, all the things you've talked about already are imperative. The STS will admit that we have been slower than we wish to be in getting there, but we are getting there. Basically, if we go through these, the highlights on this are basically making a positive impact on patient care, but to use the database for registry trials so that they can be done less expensively, we can do it more efficiently, and we can monitor new devices, a new stent graft, a new valve, things like this that we all need to know. It's not to do research. We have a role in monitoring quality and outcomes with devices as well, and we can certainly play that role. And we recognize that it takes all of us to do this together, team members. Just as Glenn Whitman talked about the anesthesiologists, we know they're always the problem, and it's not us. But that said, it's going to take a larger team than actually we can anticipate at this time. And finally, but probably the most important, is really to advance quality in our specialty. And that specialty includes all the domains we've talked about, with congenital, adult cardiac, general thoracic, LVADs, things like that. So we are, our role is seen as the platform for the United States government to come and look at these data points and to help improve the care, as Glenn said, as well as the safety. And then to disseminate what we learn in the annals of thoracic surgery. And we started that, as you know, with Alec Patterson when he became editor, with a national database series that some of you probably see when you receive the annals or when your surgeons pass it on to you. But basically it reviews what's happened in the last year in all 3 databases. The same will happen with Intermax, and we would take suggestions on how to do this, frankly, even better than we do it, and how we do outcomes. Remember, the database is really performance measurement. How you do, however, performance improvement and measure performance improvement and present these data, not just dashboards, but how you make the improvement. Right now it's individual hospitals, sometimes regional collaboratives, sometimes groups of hospitals that are in the same region, or different hospital organizations. And we haven't done as good a job of that, we meaning everyone, as we would like to. So, all these come through, and then some of the specific quality measurement task force, which is part of that council. What are we looking for this year and next year? And you can read through this, but the stroke task force is exploring risk mitigation strategies for peri-procedural strokes. Will these eventually be part of the database? Perhaps. Volume thresholds, some of you know this, for mitral valve repair and replacements. But if you look down to the next to last white one, it says explore the consistency of STS performance ratings over time as a potential adjunct to performance measurement. So the STS really is focused on how to provide data points to all of us so that we can use them to improve. Rather than just a PDF that is just a PDF, how can we help you use these data to improve your performance? Do we put more historical data in there, or what do we do? And if you look at it, since 1998, STS Adult Cardiac Surgery Database risk-adjusted operative mortality for all major procedures has dropped. Is it because of the database? Well, obviously we would all like to believe that, but perhaps it's because of data feedback, sharing more information, getting together as groups. This can all help. General thoracic over time, shorter time period, but you can see discharge mortality rates has fallen. Is it because we created the database? No, it's probably because we talked about what was in the database. And the same with congenital. Very complex world, as all as those of you who were here yesterday know about, and more to come about that. And then a congratulations to all of you. The STS National Audits started ballpark 10 years ago. Adult cardiac, all of them are over at 96% for audit accuracy. Unbelievable. You're much better than the IRS. Vastly improved compared to the IRS. So with that in mind, and this is a picture from a prior AQO meeting, we really believe you are the critical people, just as Glenn Whitman said, and I would leave you all understanding that this is really a thank you from all the surgeons you work with. These happen to be, first of all, in this display, surgeons from Michigan who all work together with our data managers. But if you wait on this slide, you're going to see many other faces that you know from the STS and perhaps even from your region. But the surgeons cannot do this without you. And I know most of you know that the surgeons really don't know what's in the PDF. So as Dr. Whitman said, and I would echo, you are the critical people. We do need your feedback. We need you coming to the microphones and saying, wait a minute, when are you going to send me those little 3x5 cards that tells me how to get on this new dashboard? So we understand we're not perfect at this. DCRI isn't perfect, STS isn't perfect, but we're heading in directions to make all this better, and we appreciate all of your commitment. So thank you very much.